Yeah, can you hear me, Giri?
Yes, madam.
Okay.
Madam, can you hear me?
Yeah, I can hear you.
Yeah.
Why are you wearing mask, Bhaskar?
There is a very big story behind it, madam. This car I'm using daily to going to a coming hospital. Madam. There is no current in my area. I'm sitting in my car and doing
Okay,
Zoom.
okay.
We can start. We can start.
Yes, madam. Madam, Anu, madam, you can start, madam. When you finish it, I will contact.
Yeah. Good evening, everybody. I have great privilege in welcoming you all to this webinar organized by the ISA Chennai City branch. In this webinar, we are having, it is a critical care topic, and it is based on IV paracetamol for post-op pain relief. It will be spoken by Prasanna Kumar, who's the consultant of Railway Hospital, Perambur, and the moderator will be Gayatri Ramanathan, who is the HOD of Anesthesia in SRM Medical College. Thank you.
Good evening, everybody. First of all, I would like to thank all of you who joined this webinar. As a continuous process, we have started our routine work. Kindly excuse the outage, power outage in my area, so my background is very dark. And I would like to thank Professor Gayatri, who has accepted to take the moderator up for this session, and Dr. Prasanna Kumar to present this topic, very useful topic, post-op analgesia management, especially pharmacology, which we do it day in and out. So thank you, and I hand over the session to Professor Dr. Gayatri, madam.
Thank you, Bhaskar sir. Thank you, Anuradha madam. I welcome you all for this session. This is CRITIQUEST Anesthesia Series 1, Post-Operative Pain Relief, Pharmacological Management. And we have a very brilliant young speaker here, Dr. R. Prasanna Kumar. He's right now working as consultant in Railway Hospital. He has done his post-graduation from Pondicherry, Government Medical College, Pondicherry. And then he did his critical care fellowship from JIPMER, and he has presented many papers, and last year, okay, he got the best paper award in Railway Conference, which was conducted all over India. So welcome, Dr. R. Prasanna Kumar. All the best, and I'm sure we are all going to enjoy a wonderful session with you. Over to you, Dr. Prasanna.
Thank you, madam. Thank you, Gayatri madam, for that introduction. I just share my screen here. Just give me a few minutes. Yeah, is my screen visible now? Yeah, thank you. Before getting into my topic, I would like to thank ISA Chennai City branch for giving me this opportunity. I should also thank Dr. Kamachi Selvam from Railway Association for considering me to give this lecture. I also thank all the participants for joining us during this difficult COVID time. In fact, it gives me a lot of pressure to present this topic because after listening to so many webinars on COVID, I think now we are all set up back to our routine anesthesia practice. Yeah, anyhow, that's a good news for us. With this brief note, I'll just get into my topic. And this is the place where I work. It's ICF Hospital in Chennai and the Government of India Ministry of Railways. So for the next half an hour or so, I'll be discussing about certain definitions of pain and its management. Importance followed by importance of pain management and followed by guidelines. Yes, we have guidelines given by ASA, American Society of Anesthesiologists. So I'll be touching briefly about those guidelines, followed by the scenario in our country, and then followed by the core topic, that is the treatment options for post-operative pain management. So moving on to the definition, I think most of you would be familiar with this definition of pain given by IASP, that is International Association of Study of Pain. So pain is defined as unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. So there are two very important things that we have to understand from this definition. The first thing is that pain is totally a subjective entity, and we don't have any tool or an investigation to find out whether the patient really has pain or not. So, so the main thing is that we have to believe in the patient. Suppose if the patient says that he or she is having severe pain, we have to consider it as severe pain, and treatment has to be provided accordingly. The second very important thing that we should understand is that pain is multidimensional. It not only has nociceptive or and nocifensive effects, it also has emotional as well as cognitive components. So that makes pain management entirely very difficult for the treating physician. Moving on to post-operative anesthesia, by definition, it means that measures taken to manage or alleviate pain after any surgical procedure. So definition might look simple, but as such, practically it is very difficult because it's not confined to the post-operative period alone. It's not like just giving an analgesic like opioid or an NSAID only in the post-operative period. Actually, your post-operative analgesic plan has to start in the pre-operative period itself. A proper pre-operative assessment followed by pre-medication, adequate pre-medication, mental and physical preparation of the patient plays a very vital role, followed by intraoperative preemptive anesthesia, followed by multimodal therapy in the post-operative period. That forms a complete package of post-operative pain management. So what is preemptive analgesia? Any analgesic strategy that is administered prior to the surgical incision or a stimulus is called preemptive analgesia. There are a lot of studies in favor of the efficacy of preemptive analgesia. So whenever possible, pain relief has to be given prior to the surgical incision itself. This will reduce sensitization and thereby preventing hyperalgesia and allodynia. Am I audible?
Yes, sir, you're audible. Sir.
Yes, yes.
Yeah, thank you for that. So moving on to the importance of pain management. I don't know how many of you are aware that WHO and IASP has declared pain relief as a human right in 2004. That means that every individual or a citizen has the right to have his pain treated or alleviated, or the right to access for pain management facility. But unfortunately, it's not true. I'll be showing the Indian scenario in my subsequent slides. And World Health Assembly also has declared that it's the ethical duty of the treating physician to alleviate pain and suffering of the patient who is under him. Pain, we all know that it is considered as fifth vital sign because it has a lot of adverse physiological effects. So it is very important that we monitor pain by using various scales like VAS score or numerical rating scores. And like any other vital parameters, we monitor in the post-operative period like pulse, BP. Pain also has to be charted. Until we chart the pain scores, it is very difficult to manage pain because it is totally a subjective entity. Humanitarian basis, yes, not only as a doctor or a treating physician, as a basic human being, we can't see someone who is suffering with pain. So we have to take all measures to relieve the pain and the suffering of a patient who is under our treatment. And finally, it improves patient satisfaction. So the adverse physiological effects of pain, I think most of you would be aware. In cardiovascular system, it causes tachycardia, hypertension, arrhythmias, and in severe cases can result in myocardial infarction also. Respiratory system, because of diaphragmatic splinting, they are at high risk of atelectasis and post-operative pneumonia, consolidation, and so on. In the GIT, it reduces the bowel movement, resulting in ileus, and anastomotic failure can also result because of poorly treated pain. Patients under pain are at high risk of DVT. This is because of a lot of inflammatory mediators are released, and a patient who is in pain is usually not ambulant. This makes them at high risk of DVT. Since once again, because of the release of a lot of inflammatory mediators, the wound healing is delayed. And chronic pain is yet another very important worrying aspect of improper pain management. So patients who are improperly treated with in the post-operative period can have chronic pain, and patients who are can land up in post-traumatic stress disorder also. That is also a worrying aspect of improper pain management. So this is how this is why treating pain is very, very important in the post-operative period. So moving on to guidelines, we have the ASA guidelines, which came up in 2012. It is an updated version. They gave the practice guidelines for acute pain management. This has been published in February 2012 in Anesthesiology Journal. There are a lot of recommendations that they've given. I've just selected a few very important recommendations from those guidelines. The first one is that a treating anesthesiologist should use epidural, intrathecal, systemic opioids, or regional anesthetic techniques after carefully assessing the risk-benefit of the patient. This has to be given priority rather than giving intramuscular opioids as and when required basis. So whenever possible, go for all regional anesthetic techniques using opioids instead of giving as and when required intramuscular opioids. That is the first recommendation that they've given. The second recommendation is that the choice of therapy should be based on the individual anesthesiologist expertise. Here, the expertise means the capacity of the treating anesthesiologist to recognize and treat adverse effects after initiation of the therapy. This is very, very important. It is not just starting a therapy. The particular anesthesia, the treating anesthesiologist should be aware of all the complications while starting a particular technique or a therapy. The third recommendation is that whenever we are using a continuous infusion, we have to continuously monitor the patient throughout the postoperative period to look for drug toxicity due to accumulation of that particular drug. So any patient who is on continuous infusion, please do monitor for accumulation of the drug and look for toxic drug toxicity reactions. So the fourth recommendation is the most important recommendation, where they recommended that whenever possible, we have to use multimodal pain management therapy. Until unless it is contraindicated, we have to go for round-the-clock regimen of NSAIDs, COXIBs, or acetaminophen. In addition to that, regional anesthetic techniques give a very good pain relief. So whenever possible, if not contraindicated, we have to use regional anesthesia, regional anesthetic techniques. So always go for a multimodal technique, regional anesthesia whenever possible, and round-the-clock regimen of acetaminophen or NSAIDs will give a complete multimodal pain relief. So the dosing regimen should be individualized based on the presenting clinical condition of the patient and the need for the patient. Whenever the patient is having severe pain, the dose has to be escalated, or you have to go for a multimodal mode of therapy. The choice of medication route and duration of therapy should be individualized based on the patient's need and clinical condition. So this is what I was talking about, Indian scenario. There's one good article that has been published in 2017 in IJA. So what they did was they did a multicentric survey in tertiary care centers in Maharashtra. They looked for the acute pain services in those hospitals. So I'll just, the results are quite interesting. I'll just share a few important results of this study. So what they found was that postoperative pain was grossly undertreated. So they found that more than 70% of the patients in our country receive experience some amount of pain. That is really worrisome. It means that we are grossly undertreating postoperative pain. The reason behind this I'll be showing in my subsequent slides. And the most worrying aspect is that the postoperative pain is treated by surgeons in most of the centers. That is what the study shows. The surgeons played a major role in pain management throughout the stay of the patient, and the role of anesthetist was really confined to the post-operative recovery room alone, or whenever the patient is on epidural, or when the patient is on a nerve block catheter or something like that. Only during that time, anesthesiologists were playing some role. Otherwise, surgeons were predominantly taking care of post-operative pain management. Might be that is one reason why pain is grossly undertreated. So moving on to the modes of therapy, they classified whether the surgeon's choice and the anesthesiologist's choice. Most of the surgeons preferred NSAIDs, IV, IM NSAIDs over other techniques, and epidural anesthesia was preferred by anesthetists. Almost 86% of anesthetists preferred epidural anesthesia. Only 65% of the surgeons preferred it. And IV or IM NSAIDs or opioids were preferred by both anesthesiologists as well as surgeons. So 86% of anesthesiologists and 87% of surgeons preferred using IV or IM opioids. And the most preferred or recommended patient control anesthesia was preferred only by 6% of both anesthesiologists as well as a surgeon. And the recommended ASA recommended multimodal anesthesia was preferred only by 73% of anesthesiologists, and only 50% of surgeons preferred using multimodal anesthesia. And when you look into the previous data, post-operative pain management was predominantly managed by surgeons, and surgeons, only 50% of the surgeons preferred using multimodal anesthesia. Probably this is the reason why post-operative pain is grossly undertreated in our country. So this chart shows the role of anesthesiologists. Almost 30 centers, 30 institutes were registered for this study, and in almost all the centers, anesthesiologists and pain management, anesthesiology role in pain management was only till the recovery room, and the rest of the period was predominantly managed by the surgeons. And round-the-clock services were available only in 6 of those 6 out of the 30 institutes, and complete acute pain services, which includes written protocol, trained medical and nursing staffs, 24/7 pain management services were available only in 2 out of the 30 institutes. So that is a gross deficiency in the part of the healthcare system. Regarding the preferences, as you see, anesthetists prefer more of opioids and surgeons preferred NSAIDs. NSAIDs, almost 92% of the surgeons preferred using NSAIDs, and only 86% of anesthesiologists preferred NSAIDs. Whereas in contrary, opioids, almost 83% of anesthetists preferred using an opioid in the postoperative period, and only 40% of the surgeons preferred using opioids in the postoperative period. That means, like, probably they are a bit afraid of using opioid in the postoperative period because of adverse effects and complications. So they also commented about what are the hurdles they faced in starting an acute pain services. So both anesthesiologists as well as surgeons, they cited that lack of pain education at all levels was the main reason for starting acute pain services. And second reason that they quoted was the lack of equipment and workforce or manpower. And finally, priority of the hospital administration. These are the few hurdles that they faced, and I think this is true because most of the centers face all these problems. This is the real picture in our country. So that's how like post-operative pain is grossly undertreated in our country. I think this has to improve in next coming years. So moving on to post-operative pain management options. So the goals of post-operative pain management should be to relieve pain and suffering of the patient with minimal side effects, and the main aim is to achieve early mobilization of surgery. That avoids a lot of complications in the post-operative period. The secondary goals would be to reduce the hospital stay and the cost of therapy. And finally, when you achieve all these things, patient satisfaction will also improve, obviously. Pain assessment, this is a very, very important aspect. Pain needs to be quantified. Until unless we know the severity of pain, it is very difficult because the treatment strategies are all focused on the severity of the pain, and the pain is totally subjective. Until unless the patient says the severity of pain, we cannot give appropriate treatment. So the gold standard scale for measuring pain would be the verbal descriptor scale, where no pain is graded as 0 and worst pain is graded as 10. Any score between 0 and 3 is considered as mild pain. 3 to 6 is moderate, and anything greater than 6 is considered as severe pain. So until we quantify and chart this pain in the vitals chart, we'll not be able to know how much suffering the patient is really having. So it is very important that we assess the pain of the patient and chart it regularly, and so that appropriate treatment is given to the patient. This chart shows the post-operative pain scores in the 48 hours. So if you see the chart, the pain scores peak between the 12 to 48 hours after surgery. So that means that this is the time period where the patient experiences maximum pain, and during this pain we have to use almost all multimodality therapy will help in alleviation of pain during this period. I think this chart, I think most of you would be familiar about it. This shows the pain pathway and the site of action of various agents and treatment modalities available. So we have the pain receptors here, which is from the site of stimulus. Pain will be transmitted through A delta and C fibers, and there we have the dorsal nerve root ganglion. From there we have the dorsal horn. Here starts the second order neuron, which goes to the thalamus, and from thalamus it goes to the sensory cortex. So we have various agents which inhibits pain transmission at that particular different levels. The first is at the site of injury. We have the COX-2 inhibitors, local anesthetics, and NSAIDs. And in the transmission, we can give local anesthetic at this part. Okay, so local anesthetic have, and some anticonvulsants also inhibit the pain impulse transmission. At the spinal cord level, we have a lot of options, like we have the spinal anesthesia, epidural anesthesia, we have alpha-2 agonists, COX-2 inhibitors, and even opioids act at spinal level. And in the CNS level, that's the central level, we have perception of pain will be inhibited by your paracetamol, alpha-2 agonists, COX-2 inhibitors, and NMDA antagonists also act at the central level. Opioid also has supraspinal effects which act at the brain level, and it inhibits the descending modulation also. In descending modulation, it has we have drugs like paracetamol, anticonvulsants, Neuraxial, opioids, NMDA antagonists, which inhibits descending modulation. So these are that's how we have to use. We have to use different modalities so that pain transmission is inhibited at different levels, so that we achieve maximum pain relief for the patient. So grossly, we can classify treatment options into non-pharmacological, pharmacological options. I'm not going to discuss about the non-pharmacological therapy. That is ultrasound. We have ultrasound, hypnotherapy, laser stimulation. We have cryoanaesthesia, electroanaesthesia, even acupuncture and TENS have been included in this non-pharmacological methods. And pharmacology, we have agents which can be classified as opioid and non-opioid. Regarding route of administration, we can give oral, intravenous, neuraxial, and regional anesthesia. Oral should be preferred over intravenous whenever possible, and neuronal and regional techniques should also be preferred in addition to intravenous drugs. Regarding modes, we have continuous infusion, systemic analgesics, or it can be either continuous infusion or intermittent boluses, or patient control versus as and when required therapy. Moving on to the drugs, acetaminophen, this is the most commonly used, and even WHO recommends acetaminophen to be used as a first-line therapy for any type of acute pain. It has analgesic and antipyretic effects, and it lacks anti-inflammatory properties. The main advantage is that it can be used for pediatric as well as adult, and even in pediatric patients, it can be used safely because it has a very good adverse effect profile. It has good gastrointestinal GI tolerability, and it does not cause platelet aggregation, so it can be safely used in the post-operative period. Patients, even in patients who are on anticoagulants, paracetamol can be given safely. But the problem is acetaminophen cannot be used for severe pain, so it is an ideal drug for mild to moderate pain. But it's used in combination with opioids whenever you are treating severe pain. So the route of administrations available are oral, rectal, intravenous forms are available. Rectal form is very commonly used in pediatric patients, and whereas oral and intravenous are preferred for adults. So the dosage is 1 gram every 6th hourly for adults, and it is 15 milligram per kg in pediatrics. Adverse effects, the maximum allowed dose is 4 grams per day in adults, and adverse effects are liver necrosis and acute tubular necrosis in severe cases. This is one article that has been published in Pain Medicine in 2011. It's a review article. They compared NSAIDs with acetaminophen. They found that IV acetaminophen has, as a first-line therapy, has a very good profile when compared to NSAIDs in terms of treating mild to moderate pain in the post-operative period. Moving on to NSAIDs, these are very commonly used in the post-operative period for pain relief because surgeons prefer using NSAIDs. And there are a lot of studies which showed that opioid requirement reduces by 40 to 50% when NSAIDs are used along with opioids. So we have ketorolac, diclofenac, ibuprofen, which are available in parenteral route. The main problem of using NSAID is that they have the risk of GI toxicity, like they can have ulceration, bleeding, and all. Renal effects. Patients on prolonged NSAIDs can have acute kidney injury, and it's very difficult to use in patients in geriatric patients also. Another problem is that it inhibits. There is a chance of inhibiting platelet aggregation because these are all COX inhibitors. So there is a risk of bleeding when you use specifically in the post-operative period. So we cannot use NSAIDs for a long term, especially in post-operative pain. Moving on to COX-2 inhibitors, we have COX-2 inhibitors. The problem with COX-2 inhibitors is most of the COX-2 inhibitors are available as oral forms, but in the post-operative period, it's very difficult to start the patient on any oral tablets. So only one drug is available as IV form, that is paracoxib. Even that is not approved by FDA for parenteral use. Celecoxib is not for pre-operative or post-operative use. Etoxicoxib, there are few studies which showed that when etoxicoxib is used as pre-medication the day before surgery, it has resulted in reduced pain scores and decreased opioid requirement in the post-operative period. So we have a good choice of etoxicoxib, and few centers use panicoxib as IV preparation, but still it is not FDA approved. Opioids are the analgesic soft choice for would be the anesthetic of choice for any anesthetist because of its high efficacy. They give very good pain relief, especially for severe pain. We have no other option other than to go for opioids. So other drugs can be used as an adjuvant, but for severe pain, we have to treat the patient with opioids in addition to regional anesthetic techniques. So these are more commonly used for moderate to severe pain. We have to go for opioids. Routes of administration: opioids are one drug which can be given in almost all routes. We can give it orally, we can give it intravenous, intramuscular, subcutaneous, transdermal, perrectal, transmucosal. It's almost available in almost all the forms. That makes us delivery a bit easier for us. But the thing is, it has a lot of side effects. So always we should go for an opioid sparing regimen. So we have the classification for opioids. We have weak opioids and we have strong opioids. So most commonly used weak opioid is tramadol in our country, whereas in Western world they use hydroxycodone. Strong opiates, as you know, routinely used is morphine, fentanyl, remifentanil, buprenorphine. The problem with buprenorphine is that it has a ceiling effect. So these are the strong opiates that we use for severe pain. So the disadvantages of using opioid is that it causes respiratory depression. That is the most worrying side effect of using opioids when used in overdoses. It can cause nausea and vomiting, which is not acceptable by the patients. Pruritus due to histamine release. Some patients, when you use for long term, they can be dependent on opioid. Ceiling effect, as I told you, certain opioids, agonists, antagonists like buprenorphine, they have a ceiling effect. If you increase the dose, further it will not produce any clinical effect. There will not be much of pain relief. So that is because of the ceiling effect that we have with certain opioids. And breakthrough pain is one thing that I just wanted to highlight, because patients who are suboptimally treated with severe pain, they have something like allodynia. Even a non-noxious stimuli can cause severe pain. That is because there are two theories behind that. One is because of central stimulation, central sensitization, and second thing is because of NMDA receptor modulation. These are the two postulated theories for breakthrough pain, and the only treatment option available for managing breakthrough pain is to escalate the opioid therapy. No other options we have other than to escalate opioid therapy. So whenever possible, we have to go for opioid sparing strategy because of all these adverse effects. So always opioids are combined with either paracetamol or an NSAID so that we reduce the toxic effects of opioids. So there are a lot of other drugs that has been tried in the for post-operative pain management. The first is ketamine, which is a very good, routinely used as an anesthetic in pediatric, but it has very good analgesic effects. So at lower doses, it is used as for post-operative pain relief, especially in children. It will produce some amount of sedation. At the same time, it will cause analgesia. Tapentadol is another newer drug. It has dual mechanism of action. One is it acts like similar to opioids. It acts on mu receptors. At the same time, it will inhibit noradrenaline reuptake. But studies are yet to get established regarding its use in the postoperative period. We have gabapentinoids like gabapentin and pregabalin. As such, they are not used as in the postoperative period, but they are very good when used in the as pre-medication, especially gabapentin when used in doses of 300 to 1200 milligram as a pre-medication on the day before surgery. It gives very good pain relief, and pain scores have been found to be significantly lower when patients were put on gabapentin on the day before surgery. Pregabalin, the results are quite equivocal because few studies have shown that there is no advantage of using pregabalin in reducing pain in the post-operative period. So among the gabapentinoids, gabapentin would be a better choice, but still a lot of anesthetists prefer using pregabalin in the pre-medication. We have alpha-2 agonists like clonidine and dexmedetomidine. Dexmedetomidine gives very good analgesic effect, but the drawback is that they can have hypotension and bradycardia, the two adverse effects with which is problematic when we use alpha-2 agonists. Corticosteroids are a very good option, especially dexamethasone has a very good effect. It acts similar to NSAIDs. It inhibits the COX pathway. Dexamethasone also has relieves post-operative nausea and vomiting. So it is better to consider dexamethasone as one of the multimodal therapy aspect. Regional techniques, we have intrathecal, epidural, peripheral nerve blocks, truncal blocks, and perineural catheters. All these things, I'm not going into the details of all these things, but intrathecal and epidural opioids have been found to be very effective in relieving postoperative pain in severe pain syndromes. Peripheral nerve blocks, definitely studies have shown peripheral nerve blocks, patients who are treated with peripheral nerve blocks, post-operative pain scores were significantly lower rather than going for systemic or intramuscular therapy. Truncal nerve blocks like TAP block, paravertebral blocks also give very good pain relief in the postoperative period, and opioid requirement will be much lower whenever we use truncal blocks. Of late, many centers started using perineural catheters. It is nothing but placing a nerve catheter, peripheral nerve block catheter next to the nerve plexus, and continuously either we can give intermittent bolus dose or we can give a patient controlled infusion using a PCA pump using these catheters. This table just shows the list of nerve blocks and it's the site of surgery. TAB block, very commonly used for abdominal procedures, and brachial plexus blocks for upper abdominal surgeries. Sciatic block for lower limb surgeries. Ilioinguinal and femoral nerve blocks for inguinal hernia repair, and lumbar plexus and thoracic paravertebral block for thoracic and breast surgeries. Of late, they started using adductor canal block and IPAC block for TKA also. So I'm not going to details of all those blocks. So what is recommended is a balanced multimodal anesthesia. What do you mean by this? Is that you use more than one drug which has different mechanism of action. It is not that you use the same drug in different routes. For example, it is not like giving an opioid IM and giving it in the epidural. You have to give two different drugs in different with a different mechanism of action. So you have to combine opioids with either NSAIDs or an acetaminophen to have a multimodal analgesic technique. So main advantage is that they have additive and synergistic effects. So unless you have a different mechanism of action, it is very difficult to have the synergistic or additive effect. The main idea of going for a multimodal therapy is that you use the lower doses of different group of drugs so that the side effects are reduced. So that is the main idea behind using a multimodal analgesic technique. So this is one example of going multimodal anesthesia. So during the preoperative evaluation, this is very important. You have to a proper assessment and proper preparation of the patient, both psychologically as well as physically, is very important. And adequate pre-medication is also very important. Pre-medications like using gabapentinoids or using paracetamol during the preoperative period have found to be produce less pain in the postoperative period. And then you assess the risk of pain depending upon the type of surgery and the risk of pain. If it is a low risk pain surgery, then the first line of drug would be to go for an acetaminophen. Then you add, if the pain still persists, if the pain scores are high, then you add NSAIDs. And then the third line would be to go for a weaker low dose opioid. If the patient, the pain is moderate, then the first line of therapy would be to go for, once again, acetaminophen. You add NSAID. In addition to that, you go for a weak opioid. If possible, whenever possible, consider placing an epidural catheter or continuous nerve block catheter during for treating mild pain. For high pain, we have to go for strong opioids, and pre-medication is very important. Or for all these patients where you expect very high pain, we have to give very high. We have to prepare the patient properly. Adequate analgesic in the preoperative period, intraoperative preemptive analgesia, and postoperative multimodal therapy with a strong opioid is considered in these patients. Sorry for the clarity of this picture, but what it says is that we have mild, moderate, and severe pain, and IV acetaminophen or paracetamol is used for from mild to severe pain, and NSAID is start once if the patient starts having moderate to severe pain, and opioid as and when required for mild to moderate, and if the patient has severe pain, you go for a regular dose of opiate. So whenever a patient has severe pain, the patient will be getting acetaminophen, NSAID, and opioid. In addition to that, you should take the help of regional anesthetic technique using local anesthetic. That is another aspect. So to summarize, So adequate preparation is adequate preoperative preparation of the patient is very, very important. Preoperative physical as well as psychological preparation with adequate pre-medication plays a very vital role. Preemptive anesthesia in the form of either local anesthesia, local infiltration, or using epidural or spinal anesthesia is to be considered in each and every patient. Multimodal therapy using different drugs with different mechanism of action. Using different routes is preferred. It's ideally what is recommended by even ASA, and many centers do follow this multimodal therapy. Using regional analgesics whenever if it is not contraindicated will help in reducing the opioid requirement and thereby drug accumulation and toxicity. In the post-operative period, it is very important that we monitor the patient continuously for pain scores. We should also look for drug accumulation and toxic side effects, and treatment has to be provided as and then required. So the choice of drug and drug dosage and the route of administration has to be individualized depending upon the patient condition and the need of the patient. Most important thing, what is recommended by the American Society of Anesthesiologists is that every center has to establish acute pain services. Establishing acute pain services means a center should have 24/7 a dedicated pain service team. Regular training of the medical and paramedical people has to be given, and there should be a written protocol, and the post-operative continuous monitoring of the patient has to be done properly. So that forms a complete acute pain services. But most of the centers in our country, we don't have acute pain services. So it is very important that we start establishing acute pain services so that post-operative pain is treated properly for our patients. So these are my references for this. Yeah, thank you.
It was a wonderful presentation, Dr. Prasanna.
Thank you.
Excellent. You started really well, and then every aspect was really covered. I myself learned a lot from your presentation. I'm simply not lifting you up. Honestly, I'm telling you, it was really, really good. Okay, and I have just one or two questions before we leave it to audience to ask. What do you think? What is your opinion about opioid-free anesthesia? Is it time to do away with opioids now?
No, madam, no. Actually, for mild to moderate pain, you can avoid, but for severe pain, it's better to go for an opioid, because the pain relief, when you start increasing the NSAIDs or acetaminophen, you start getting the toxic effects. So that's why you always go for a multimodal therapy, especially for severe pain. For mild and moderate pain, okay, you can avoid opioids, but then whenever patient, the problem is for post-operative pain. More than 80% of the surgeries will have moderate to severe pain. So we are left out only with opioids. Only thing is we can reduce the dose of opioids. In addition, we can add either NSAIDs or acetaminophen as an adjuvant, so that we reduce the toxicity of opioids. At the same time, adequate pain relief is given by a combination of all these three drugs. For mild to moderate pain, yes, madam, we can avoid, but for severe pain, definitely no other option other than to go for opioids.
Yeah, very true. Yes. Now, one more question. Many times in my hospital itself, the medical superintendent and all these people, they come and complain. You filled PSU with patients on epidural, patients on blocks, like that. Okay. Do you recommend giving all these, whatever, infusions, patient control, analgesia, epidural infusions and all in the ward, or it has to be in the ICU setup only?
Better whenever patient is on a continuous epidural catheter or a nerve block catheter, it is better to be under the purview of treating anesthesiologist rather than shifting the patient to a ward where it is left without caring. So it is always better to keep a patient in a dedicated post-operative care unit rather than an ICU. Instead of, you need not keep the patient in ICU, a dedicated post-operative care unit where anesthesiologist is looking after the catheter, so that the chances of infection, handling the catheters are taken care of really. So that would be my opinion regarding that, madam.
Yeah. Okay.
Better not to send the patient to ward. Yeah.
Yeah. Post-operative ward, will it be okay? Or how is it abroad or in other places where this acute pain services are there? Where do you keep such patients?
Yeah, yes, madam. They have dedicated acute pain services patient. They keep the patient in the post-operative ward, where it is a team consisting of a physician and nursing paramedical. Predominantly, the caring is taken care of by the nursing paramedic. They give adequate training. The frequent CMAs, CNEs are being contracted so that all these people are adequately trained. So that is the biggest advantage that they have. But whereas here in our country, the biggest problem is we don't have a proper acute pain services and we don't give adequate training. So moreover, the biggest problem is that anesthesiologists are confined to the post-operative, and that too in the recovery period alone. The rest of the part is taken care of. In most of the centers, it is taken care of by the surgeon. That's what that even the trial had shown.
Yeah.
So that is really a worrying part. So as pain management physicians, as expert in pain management, anesthesiologists are not really doing their job in our country. It is predominantly taken care by surgeons. That has to be done by anesthesiologists. I think if that has been done, most of our patients will have adequate pain relief in the post-operative period. That would be my opinion.
Yeah. Okay, one last question. We have so many new blocks which have come up, isn't it? Like we have sartorius block, we have 3-in-1 block, we have femoral nerve block. So for so many are there. So what do you want the modern anesthetist to do? Should he just limit himself to epidural or move away as closer to the site as possible?
Yes,
What is your
actually, as per according to that recommendation, you have to go for regional anesthetic, regional techniques whenever possible. That depends upon the expertise of the treating anesthesiologist. If the treating anesthesiologist is confident enough in managing the complications of the technique what he is following, then better to go for a regional technique. In addition to that, he can supplement it with the systemic analgesics. Otherwise, if he is not confident enough, then it is better to avoid all those regional anesthetic techniques. That's what the recommendation also says. So always it is preferred to go for regional techniques. But if the treating anesthesiologist is not confident enough in managing the complications, better to avoid it. That would be my stand.
Okay, I'll just check in the chat whether there are any questions. Okay, yeah, then I'll just okay. I'll go from down. Many people have commented that it is a very good presentation. Okay, and somebody has asked, can paracetamol be given to patients with poor hepatic reserve and renal reserve?
No, ma'am. Yes, actually, it depends upon the severity. For mild to moderate disease, still you can consider paracetamol. But for severe disease, if the GFR, if the patient is having a very high grade hepatic failure, or if the GFR is less than 30, then it's better to avoid.
Yeah. Oh, yes. And one more question is there: can paracetamol be given in the immediate post-operative period when there is a hypothermia which is still uncontrolled?
Yes, yes. Yeah, sure, madam. It can be given. There's nothing like it is contraindicated in hypothermia. If it is considered for pain management as such, it can be considered. There is no data that paracetamol is contraindicated in patients with hypothermia. So for pain, if it is considered, it can be used as one of the component of multimodal anesthesia.
And the same Dr. Thiru Gnana Sambandam has asked, how much is a single maximum dose of paracetamol that can be given during a surgery?
Yes, madam. The maximum dose is 15 milligram per kg single dose, but the total per day dose should not cross more than 4 grams. So that is the recommendation for paracetamol. So and the time duration is once if you give a bolus dose, there should be at least 4 hours, minimum 4 hours gap for the subsequent dose. So it will not be given very frequently also. And the total dose is the maximum allowed dose per day is 4 grams per day.
Yeah, that is very clear answer from you. Now, next one question from Kumar Ramanathan. He's asking whether will you consider IV lignocaine and magnesium for pain relief?
Yes, madam. Actually, there are a few studies, but use of IV lignocaine and magnesium, as an individual therapy, they have not shown much of benefit in the postoperative period. But yes, there are very limited data available on the efficacy of lignocaine and magnesium in the for postoperative pain relief as such. But can be used. There are magnesium has been used as an adjuvant for local anesthetic in through epidural and peripheral nerve block catheters. And even lignocaine, IV lignocaine has been used that produce some amount of anesthesia and prevents arrhythmias also. But as such, the data are very limited for its use in postoperative pain, and its efficacy is also doubtful only in the postoperative period as individual agents as such.
This same Dr. Tirunana Sambandam, he has told, DEXA, you've already told it, no, steroids definitely help, but the same thing he has asked. And one more question he has asked is, what is complementary synergism?
Complementary synergism means like the potentiation of the effect of opiates. For example, NSAIDs, when it's used, NSAIDs or paracetamol, when it's used along with opioids, it will increase the anesthetic efficacy of, not only it decreases the side effects, it also increases the decreases the pain score significantly. So that is what we call it as synergistic, additive synergism, or
Okay, I think he's pain specialist himself. He has bombarded you with a lot of questions. One more I'll ask from him, then I'll see whether anybody else has asked. Now he's asked one more question. What is opioid paradox?
Opioid paradox.
Yeah. Yeah, almost everything else you have answered. Okay, yeah. So this, I think, Dr. Tirunana Sambandam, if you know the answer, you can put it in the chat box. We would all like to know. Probably it looks like you know everything because you've bombarded the speaker with so many questions, right?
Excuse me.
Yeah.
What is a speaker's take on transdermal opioids? That is also asked in the chat box. Transdermal.
Actually,
transdermal.
Transdermal opioids can be considered, but the problem is that the systemic absorption is totally unpredictable, and it depends upon the blood flow, because in the immediate postoperative period, patient will be hypothermic, and the subcutaneous blood flow will be very variable. In that condition, using transdermal patches, it's totally unreliable. So that's why it is not very commonly used.
Yes.
Not very commonly used in the postoperative.
Yeah. Not by anesthetists, more commonly used by surgeons.
Madam, personally, I used on myself after my surgery. After my surgery, it was used on me, and I felt the pain relief was good. But after some 2 to 3 days, what he tells is correct. Hypothermia would be probably interfering with the absorption. But after 3 or 4 days, it gave a very good pain relief for me.
Yeah, even I had a good pain relief with using this buprenorphine patch.
You should appreciate your anesthetist, madam.
Madam, I appreciate it. Madam, I thank Dr. Giridharan, madam, for that. Let me openly tell it.
No, it was used. Yeah, I used buprenorphine patch was used.
So one thing I would like to share regarding the epidural management of pain relief. In all replacements, I have been using epidural pain relief for the past 15 years. About post-op care, if you are using a fixed delivery pump, like a pump of isomeric pump, then you can very well shift the patient to the room. You can initially observe the patient for 6 hours, and then you can shift the patient to the ward, and can be monitored in the ward itself. Because if it is a fixed delivery, that is, most of the patients are more comfortable, and hemodynamic stability is also not disturbed to that extent. This is my personal view. And I use as an adjunct of a fentanyl patch, along with the very low dose of 0.1% of bupivacaine for pain relief. So in our setup, when you put it into an ICU, the cost factor will be the more than the fees of the anesthesiologist.
Yeah, I second Giridhar. I've also used elastomeric pumps. For the first 12 hours, we keep it in the ICU, and then I've shifted the patient to the ward. So the nurses are tuned to that, and they manage well. It is how you teach them. So it is not necessary that you have to keep the patients in the ICU. It is not recommended at all. Yeah.
So, and the paradoxical opioid paradox, that means even the patient is receiving opioids, that pain is still persisting. By increasing the dose of the opioid also, the response of the pain by the patient, perseverance is there. So instead of getting a pain relief, still the patient have the painful, they sense the painful stimuli. So this can be avoided by an adjuvant of an NSAID or a combination of a sedative to give a good pain relief. That is going to be what is discussed as opioid paradox.
Breakthrough pain. Yes.
Opioid paradox.
Sir, is it same as breakthrough pain what we discussed?
Yeah.
Or is it different?
It is almost like that. Even though you give opioids, the pain stimulus is being perceived, and they think that it is perceiving as a pain. They are not completely relief of pain. When you combine with a sedative or a non-NSAIDs along with the opioids, they get the pain relief. So this is called as opioid paradox. When you give opioids, your pain should come down. It is not coming. And how to abolish that pain is by an adjuvant.
Yes.
That is what is called as an opioid paradox.
Sir, and regarding that, using elastomeric pump, one biggest problem is that it gives a fixed flow. It is very difficult to titrate
yes.
the flows. It goes in a fixed flow. Whenever the patient has, it's very difficult to escalate or de-escalate the flow rate. That is one big problem with which we face.
We use paracetamol when there is a big pain with the elastomeric pump. We supplement it with paracetamol.
Okay, madam. Okay.
So how is about paracetamol usage in pediatric age group?
Pediatric, yes, sir. It's safe both in pediatric as well as geriatric age group. The dosage is 15 milligram per kg. It is safe, and many centers they use suppositories, paracetamol suppositories for pediatric groups. So whenever possible, go for a non-parental route. If that is not giving adequate pain relief, then you can go for intravenous preparation also.
And one question actually in the chat box: why is the dosage of IV paracetamol is more than oral paracetamol?
Sir, there's no much of difference between oral because it is almost the same dose that we give for both oral as well as, because the absorption is very good and there's no much of difference. I don't think so there is any difference between oral as well as.
And initially when paracetamol came into the market, this was the topic of discussion. The reason for that is you can use 4 grams in case of paracetamol when you give IV, whereas your dosage of paracetamol cannot go more than 1,500 to 2,000 grams, 2,000 milligrams per day. So the reason is the portal absorption by oral, so bioavailability is more. So directly as it is given by IV, it is bypassing the hepatic circulation. So that is the reason it was described that IV paracetamol is on a higher dosage than the oral paracetamol. That was the study given. And due course of time, by the evolution of multiple usages and studies, they have said that it is more or less equal to as that more big difference is there.
Yes, sir. Now there is no much of difference between oral and...
Initially, it was said that because of this reason. Then as it has been used in a larger patients and more in numbers, this has given a insignificant values. And toxicity is going to be patient responsive than the route of administration.
Okay.
If there is,
yeah,
madam,
there's
there is no question, I think.
There's
proceed, please. Yep. Please proceed, madam. Please proceed.
One more last question, sir. I think with that we'll end. Here's this Kappian Tamil has asked whether routine use of pain scales is clinically more effective in providing pain-free post-operative period.
Routine use of PCA, madam.
Pain scales. How often do you use pain scales?
Yes, madam. Actually, as per recommendation, pain is considered as fifth vital sign, like how you record your BP, pulse, heart rate, SpO2 in the post-operative period. One column should be left for pain scores. So that has to be assessed at least once in 2 hours, so that you know what exactly the pain the patient is experiencing. So until we know the scores, it's very difficult to pay. Suppose if the score starts increasing, then you have to add an adjuvant to whatever you are giving already. So ideally what we do is the recommended is like any other vital parameter, pain scores are to be monitored in the immediate post-operative. At least for 48 hours, patients are to be monitored using pain scores. That's what is the recommendation says.
Okay, thank you very much, Dr. Prasanna. Wonderful answers. And I think the one who answered is Dr. Tirunavakara sir. I couldn't see his face. He was not spotlighted. It would have been nice if you could have seen him also. Thank you, sir. You also, improved the quality so well. So many useful things you also told. Over to Bhaskar, sir.
Good evening, everybody. Sorry, I didn't switch on my video. The current is yet to come. I would like to thank Dr. Prasanna for his elaborate but very concise and precise presentation. It's a very nice overview. After a long time, because of this COVID, we have been hearing more things on COVID, and now I think we have started to come out of this COVID scariness. So I should thank him for taking a literally tough topic and presented very well. And I also thank Gayatri Madam for a very nice moderation of this session, and she gave opportunity to present all the questions. And as well as Dr. Tirunavakara, who has raised them almost 9 to 10 questions on this thing. And I thank the people, Alchem people. Now I call out the company representative to present their own presentation on paracetamol.
Vinay, voice is not audible. Vinay, it is not audible.
Alchem has brands like Sumo, things from Alchem Laboratories. Doctor, as you know that Alchem is the 5th largest pharmaceutical company in India and present in all major therapy areas. Globally, Alchem is present in 56 countries and having strong presence in US market with more than 125 ANDAs. Doctor, Alchem Laboratories has 14 brands in the top 300 brands with a strong presence in pain management. In this segment, Alchem has brands like Sumo, Enzoflam, Hospimol, Gemcal, Uprise D3 and many more. Doctor, Alchem Hospicare is the highest growing company in critical care in financial year 2020. It is perceived as the true ICU care division of Alchem. Hospicare is dedicated towards serving critical care and it stands notable among the fraternity for need of quality medicines. Doctor, pain management is an integral part of the treatment in hospital care. Paracetamol is the most preferred molecule for primary pain and fever management due to the safety profile. Available paracetamol containers are conventional and difficult to handle. Hence, need of the hour is novel approach. Paracetamol is the most widely used molecule in hospital service since 1880s. IV paracetamol reaches a significantly higher 70% maximum concentration within 15 minutes of infusion and so is one of the most favorable NSAID. A study in moderate number of patients shows that paracetamol reduces the requirement of opioids, a decrease by 14.9%. IV paracetamol has broad compatibility with other analgesics. IV paracetamol improves pain relief, expedites mobilization and rehabilitation, and reduces healthcare costs. Introducing a novel drug delivery system. Hospimol quality with flexibility. Doctor, Hospimol FlexiBag offers closed infusion system to maintain aseptic conditions. Hospimol FlexiBag has 2 ports, hence no external venting is required. Doctor, Hospimol FlexiBag is a self-collapsible or flexible non-PVC bag which provides greater durability. Hospimol FlexiBag is also environment friendly. Unlike other PVC bags, it does not release toxins of HCl and is DEHP free. Doctor, Hospimol FlexiBag is easier to dispose as compared to other containers. Hospimol FlexiBag has reduced weight and there are no chances of breakage. Doctor, Hospimol FlexiBag provides triple E benefit: ease of handling, ease of storage, and ease on environment. Doctor, please prescribe Hospimol FlexiBag to your next patient to ensure quality with flexibility. Doctor, Hospimol FlexiBag is available in your hospital pharmacy.
Thank you for the patient hearing. This is Dr. Hemant from Medical Advisor Alchem Labs. First of all, I would like to thank Indian Society of Anesthesiology, Chennai City Branch, President Dr. Anudha Madam, Secretary Dr. Bhaskar, for allowing Alchem to be part of this scientific activity. It was really nice to hear a very good talk by Dr. Prasanna and equally well moderated by Dr. Gayatri. Thank you once again to all the viewers for patient listening on this Friday evening. Just to add, we already heard Dr. Prasanna speaking about role of paracetamol. Now, Alchem brings a difference with the flexi bag by means of a non-PVC and a non-DHP. These are plasticizers basically, which create toxins and might be harmful to the patient and also to the environment. And that's the difference which Alchem wants to provide it to the healthcare and also benefit their patients. So once again, I thank all the viewers, panelists, office bearers, the speaker, and the moderator. Warm greetings from Alchem. Thank you, everyone.
So now I call upon Dr. Giridharan to give the vote of thanks. Giri?
Yeah. Good evening, all. After a long time, we have been in association with the CME program. It's a different experience as a webinar. I thank Dr. Prasanna Kumar for excellent presentation and a nice discussion about IV paracetamol as a pain relief. And I also thank Professor Gayatri Madam for excellent coordination and putting forth the questions from the audience to the discussion. I personally also, on behalf of ISA, I thank Alchem Laboratories for organizing as a co-organizer of the CME program. I thank the members and the viewers who have participated in the CME and gained knowledge regarding the pain relief or post-op pain relief. I personally thank Dr. Thirignana Sambandam for putting forth a lot of questions and making the session active one. Thank you. Thank you.
Thank you.
I think we can come to end of this session. I thank everybody again. Thank you, sir.
Why can't you spotlight Thirignana Sambandam? I think Dr. Gayatri wants to say.
TNS is a very famous figure, madam. No need to spotlight him.
Gayatri wants to see. She's not seen him.
Fine, madam.
Okay.
Thank you, madam. Thank you, everybody.
Thank you.
Yeah.
Thank you. Vinay, we can
Thank
call
you.
it off.